One of the shortcomings of a lot of the approved drugs is that they don't fully address negative symptoms. And based on the data that we've seen so far from your phase 2 and phase 3, it appears that brilaroxazine does have an impact on that. Why don't you explain that, how brilaroxazine helps with negative symptoms and the unmet need there as well?
Sure. So at the beginning, when we discussed about the mechanism, certainly from first generation drug where pure dopamine selective to second generation drug with the 5-HT2A activity, it certainly benefited patients in addressing to some degree negative symptom and depression. But the amount of the activities for serotonergic activity, it's not sufficient enough to address negative symptom and depression. That's what treatment is incomplete. So why I say incomplete, if you look at, pick any drug currently available, often with the total PANSS score as a primary endpoint, these drugs got approved to market. So these are acute patients treated in hospital. And then at that time, positive symptom is the major symptom domain, even though these patients have at varying degrees of negative symptom. But the primary goal is to address positive symptom and then get these patients out of hospital. Mm-hmm. So that's what most of the drugs, primary endpoints you can assure of. So the challenge comes once they get out of the hospital through acute symptoms. The negative symptoms, if not addressed properly, then treatment becomes incomplete. After a few weeks or months, they end up in again hospital because of the relapse. Right. So that means the serotonergic activities to address negative symptom is suboptimal with these drugs. With our drug, at least when we designed this molecule, we noticed that beyond 5-HT2A at a therapeutic dose, if we are able to improve the D4 activity, 5-HT2B activity, and then 7, this can immensely benefit these patients to address depression component that is very closely associated with negative symptom, and then vice versa. So we have potent activity for 5-HT2B that's almost 3 times more potent than dopamine activity. So that 5-HT2B further benefits these patients considered as a upstream target for addressing neuroinflammation. So the combination of addressing directly the negative symptom through serotonergic activity, addressing neuroinflammation. So our drug benefited these patients in providing a broad spectrum efficacy, going beyond positive symptom to negative symptom, depression, and cognitive function. So when I say this beyond positive symptom, what evidence we have? So we have completed multiple trials in 2 randomized trial in acute schizophrenia patients in 4 weeks, kind of identical protocol. Mm-hmm. And then long-term treatment in stable schizophrenia. Stable schizophrenia patients are reflective of you treat patients, they get out of the hospital, and then they need medication for a long time. They take medication at home. So in the real world experience. So we have seen a sustained efficacy in these patients treating over 1 year. When I say sustained efficacy, if you look at the clinical literature, pick any approved drug currently in the market, on treatment, in 1 year, it is reported around 25% patients discontinue, and then discontinue with the relapse, they end up in hospital. Okay. So we hardly seen any patients got relapsed over 1 year treatment. That means the efficacy with our drug is sustained and durable.